Hello, everyone, and welcome to a Rural Prep Professional Development webinar. It's actually the first in our series for this upcoming academic year. I'm Randy Longenecker, Professor of Family Medicine and Assistant Dean at Ohio University, Heritage College of Osteopathic Medicine, and Associate Director for Rural Prep. And I'm joined by my co-host, Davis Patterson, Research Associate Professor, Department of Family Medicine, and Project Director for Rural Prep. We together want to welcome Jennifer Burgess from the Federal Office of Rural Health Policy and Marcia Ward from the University of Iowa as our presenters today. And finally, I want to welcome all of you as attendees and hopefully participants, more than attendees, following our presentations. Here's our agenda for the day. Following my brief introduction, we will have presentations by Jennifer Burgess and Marcia Ward. So Rural Prep is the collaborative for rural primary care research, education, and practice. It's an acronym. And it's part of HRSA's Bureau of Health Workforce Initiative to promote a community of practice in evidence-based training and education of professionals in primary care. Our mission and focus is to improve and sustain rural health through community engagement and research in rural primary care health professions. And we include nurse practitioners, physicians, assistants, and other members of the primary care team in doing this. This webinar is an effort to engage you in our community of practice. These professional development webinars are intended for rural health professions educators and researchers, whether you're faculty, student, resident, or anyone else who has an interest in the topics that we present. And these generally occur on the fourth Thursday of July, December, May, and June. The objectives of today's presentation are to help you to learn to access the Rural Health Research Gateway and the resources that are available there, articulate some goals of research in rural health, and describe the relationship between the various entities that we'll hear about. As always, our goal is to encourage you to join our community of practice in the work that we have before us. So without further ado, I'd like to proceed with our presentations. And as Jennifer is sharing her screen, I want to say we're very pleased to have her represent the Federal Office of Rural Health in describing the landscape of rural health research from a national perspective. And we're also pleased to have Marcia be with us and provide a case example in the area of telehealth. They both will introduce themselves as part of their presentation, and we look forward to that. Jennifer?
Thanks, Randy. Hi, everyone. Thank you for joining today. My name is Jenny Burgess, and I am the Research Coordinator for the Federal Office of Rural Health Policy. Quick background about my office. The Federal Office of Rural Health Policy was created over 30 years ago to advise the Secretary of the U.S. Department of Health and Human Services on healthcare issues impacting rural communities. Those issues could include access to quality healthcare and health professionals, viability of rural hospitals, and the effect of the department's proposed rules and regulations, including Medicare and Medicaid, on access to and financing of healthcare in rural areas. FRHP plays two distinct but complementary roles in HHS. One is to advise the Secretary on rural policy issues and across the department and support policy relevant research on rural health issues. And then the second is to administer grant programs focused on supporting and enhancing healthcare delivery in rural communities. So I'm going to focus mainly on the research side of things, but if anyone has policy related questions regarding rural health, I wanted to include this email because these two topics are very closely intertwined, and FRHP does everything we can to make sure that stakeholders and professionals and relevant policymakers have access to whatever answers they need regarding policy questions. So the Rural Health Research Center program is the only federally funded research program entirely dedicated to producing policy relevant research on healthcare and the health in rural areas. We work with other agencies within the Department of Health and Human Services to advise and direct them when they are doing things, when they are doing research and program development and work in the rural spheres as well. The research centers each have their own identity, although it may be part of a larger organization. They each have their own website, and they have a core staff that include a disciplinary mix of health services researchers, epidemiologists, public health professionals, geographers, professionals in medicine and mental health. And over the 4-year cycle of the Research Center Award, each center develops a portfolio of several research products per year in conjunction with input from FRHP. So to strengthen the dissemination of those research results, the Rural Health Research Gateway was launched in early 2006. The Gateway is a one-stop shop for the rural health research centers, providing easy access to projects funded by FRHP and summaries of the research that is in progress. So here are the logos of all 8 of our research centers right now. Sometimes when we have additional funds come from other agencies or other bureaus within the Health Resources and Services Administration, we're able to fund a 9th center, but these are the 8 traditionally funded research centers. And each of them have focused topic areas that they specialize in and are subject matter experts in. Focus areas could include health system challenges and models, Medicare and Medicaid policy, rural health disparities, including among communities of color and women, rural providers, quality of care, primary care, substance use disorder, and telehealth. So as I mentioned, to strengthen the dissemination of our research results, we created another cooperative agreement called the Rural Health Research Gateway. And the Gateway makes funded research available to stakeholders at the national, state, and local level with a goal of informing and raising awareness on key policy issues. If you are interested in getting up-to-date research released, you can sign up for their alerts, and all new publications will be available that way. And just so that's not intimidating, this website is really user-friendly, and you can browse research by topic, or you can search for research in the topic in the search bar. And it's, again, very friendly. I highly recommend, if you haven't checked it out already, you go there and just browse the topics and see what's of interest to you. And if you see something missing, reach out to the director of the Gateway or reach out to me and give us the advice that you have from your expertise. So the goals of rural health policy relevant research within FRHP are pretty clear. So data collection and analysis is essential to understanding the challenges in rural communities, the impact of policy on rural communities, and helping to set policy for future. The work of the Rural Health Research Centers informs the work of FORP's policy analyst and team, and vice versa. So research is needed at every one of these stages. We might see a challenge in a rural community, or a rural community might present a challenge to us that needs to be researched. This could be a very recent topic would be the maternal health crisis and access to obstetric unit services. That was a topic that was brought to the Federal Office of Rural Health Policy by community stakeholders. And then we decided that that warranted research, and we asked one of our research centers to do that work. And now the University of Minnesota is the leading expert on obstetric unit closures and access to maternal care. Another area we create research questions is around policy changes. So our office, as I mentioned earlier, has access to regulations and legislations from the Department of Health and Human Services. And our policy analysts are often given the opportunity to comment from the rural lens. And we use our rural health research centers to inform the comments that we make in that capacity. And so if we don't have recent or relevant research in a certain area that policy change is happening, then we can ask our research centers to do that work to better inform our comments on those policy changes. On the other hand, sometimes policy is enacted and we need to look at the impact that that has on the rural community. So sometimes our research centers are tasked with evaluating the impact that those changes have had. And that's kind of where we get this cycle of research and policy and the information that is shared within all of these different spheres. And so today we are lucky enough to have Marsha Ward, the director of the Telehealth Focused Research Center, on the call to talk more about this relationship and her experience as one of our rural health research centers. So at this point, it's my pleasure to pass the mic to her.
Thanks, Jenny. And so hello, everyone. I'm Marsha Ward, and I'm talking to you from Iowa today. And I direct the Rural Telehealth Research Center. And we are, as Jenny has introduced, one of the rural health research centers funded through a cooperative agreement with the Federal Office of Rural Health Policy. And while all of the research centers have various topics that they're particularly expert on, we're the one where FORP has said there needs to be a research center that's specifically focused on telehealth. And part of the reason is that FORP has an office for the advancement of telehealth that is really central to providing grant support to a lot of healthcare systems, providers around the country to expand telehealth in rural areas. So when we were funded 5 years ago, our charge specifically was to help build the evidence base for telehealth. And we actually include researchers from 3 of the rural health research centers here at Iowa, the research center at North Carolina, and also at Southern Maine. So this gives us a lot of strength in terms of researchers with skills and backgrounds. So when we started all of this, FORP had a vision for how we could be most helpful. And the vision had to do with their funded research projects in a number of different clinical areas focused on telehealth. And I'm going to talk mainly today about their program to support and promote and advance access to telehealth in rural emergency departments. So rural emergency departments, especially critical access hospitals, must provide emergency department services 24/7. There's a few primary care providers usually in those communities. I know that's true here in Iowa, where we've got 80 critical access hospitals, and I've visited a lot of those, and they will often have 5 primary care providers in their communities, made up of MDs, DOs, PAs, and NPs. So expanding this program, they're the ones that are staffing the rural hospital emergency departments, And so this program specifically looked at hospitals where telehealth was used. And when FORP introduced this funding opportunity back in about 2015, they ended up funding 6 networks across the country that were charged with expanding, promoting, providing telehealth services to rural hospital EDs. And those 6 networks ended up doing so in 65 rural hospitals across 13 states. I want to emphasize these networks were not told by FORP how they must deliver telehealth. So all of them operated in different ways, figuring out what was the needs of the communities that they were serving, what sort of services they could provide. 3 of them were academic medical centers. 3 of them were other sorts of telehealth networks. So it's quite a variety of approaches. So where did we come in? We were funded at about the same time, and again with FORP asking if we would take on a role essentially to help leverage the work that was being done by these grantees, and to figure out if there was a way to capture the learnings, capture the learnings from those networks. So what we ended up doing was a big literature review on tele-ED, identifying measures that were used in the published literature at that time, identifying a set of metrics that were out there by organizations like CMS, ARC, and coming up with a list. Then we worked with the 6 networks back and forth with what was practical for them in terms of collecting data. We definitely wanted to limit or reduce as much as possible the burden that they had in terms of collecting data. So we ended up with 45 data elements. These included some basic patient demographics, presenting complaint diagnosis, disposition, some timing factors on when the patient arrived in the ED, left, when the consult began. And then we focused specifically on 4 serious conditions that present in all emergency departments. These happen to be chest pain, AMI, stroke, and sepsis. And we added specific process measures related to those 4 conditions. So we created a data element dictionary, an Excel-based tool for them to enter the data. And over a 26-month period, they collected data on all of their patients where tele-ED was used. And so this ended up being over 4,000 patients. We also asked them for these 4 conditions to identify patients where tele-ED was not used, and find patients that were at the same hospital, same diagnosis, age. We gave them a set of variables to match on. So I want to share with you the findings from these different conditions. And we've now been able to publish 3 papers. And I chose these because they were more clinical for you, the audience. And so the first one, we combined chest pain and AMI. And I'm sure you know these are serious conditions, time sensitive, and that there's been evidence-based clinical practice guidelines around for years now on best practices. So what needs to happen in the emergency department when a patient presents with chest pain or AMI? And we had measures around those processes of care that included things like time to an ECG, time to treatment, and in fact, whether fibrinolysis was actually administered. It turned out that there were over 1,200 patients that presented with chest pain, and about a quarter of them received tele-ED was activated by the local rural providers. And so the local rural providers in the emergency department basically can press a button or something to call up the service that they're connected to. And so they're often connected to a larger hospital, which is the hub, where there are board certified emergency medicine physicians and other specialists at the press of a button on demand, usually within a matter of seconds to get that connection. And so the local rural provider decides whether for any particular case they want to pull in that sort of a consultation. So for the quarter of the patients that presented with chest pain, it turned out that time to ECG was in fact significantly faster than those other 3/4 where it was not used. And also they had higher odds of receiving fibrinolysis. So both a process in terms of diagnosis and a process measure in terms of treatment. Now I'm going to turn to stroke, and this is a similar situation, very serious. Timely treatment is of the essence, timely recognition of stroke symptoms and then treatment. And so our outcomes included both diagnostic and treatment. In this case, across these 6 networks, it turned out that there were about 900 patients that presented with stroke symptoms, and about 1/3 of them received a teleconsult. Like with chest pain and AMI, in this case, those that received the consult were more likely, significantly more likely to have a timely head CT interpretation, which the metric is within 45 minutes. And they were, of the eligible patients, it turned out that the ones where there was the tele-ED consult also had a faster time to the administration of TPA. The final one is sepsis, and sepsis, again, a life-threatening emergency, and where for stroke, chest pain, AMI, the measures for that have been known for years. Sepsis has gotten more recent attention. There now is a recommended bundle of 4 components that should happen in the emergency department for sepsis patients. And I'll say these are actually changing a little bit over time as professional organizations, government entities are weighing in on these. But we collected the ones that were available during this time period. It turned out that there were 655 sepsis patients over this 26-month period in these 6 networks. Only 5.5% received a tele-ED consult, and this is probably because sepsis is often not recognized as such. But for those patients who received a tele-ED consult, they did have the whole bundle completed at a higher rate, and they also had 3 of the 4 components of the bundle completed at a higher rate. So we think that these findings are quite important clinically, and they also have policy and practice implications. So stepping back a little bit about telehealth, and let me clarify, telemedicine and telehealth, the terms get used often interchangeably. Telemedicine is usually applied more to the actual clinical delivery of care using telecommunication tools, where telehealth tends to be a broader term, including education and other sorts of applications of it. In terms of telehealth, first of all, it's costly, and it is an implementation of technology and system change, and all of that has a lot of complexity. So in a small rural hospital, the administrators, the clinical staff need to figure out, in fact, whether to invest in this or not. And cost is definitely a barrier to that. And whether the clinicians are really on board, whether there's champions for bringing this sort of a service into their small rural hospital. What complicates all of this is there's actually been significant restrictions on the use of telehealth. It's been around for decades, but a lot of restrictions having to do with policies, regulations, Medicare and Medicaid limit reimbursement. And I'm talking now just pre-COVID-19. So all this research was done in a period of things have obviously changed right now, but talking pre-COVID, there were limitations in terms of whether Medicare and Medicaid would reimburse, and also other sorts of policies like medical licensure, credentialing, those sorts of things that restricted it. Some of those policy restrictions, regulations, they've been decreasing over time, but there's still some challenges there. So, you know, if I present something and it indicates telehealth is fabulous, why isn't everybody using it? It's because there are these barriers. So one way to influence clinicians and policymakers is to produce solid research findings that in fact show that it's at least as good, but preferably better. And so our research findings have contributed to that. We have shown significant improvements in care processes when tele-ED was used. Now, a real strength, and this is unique, is that we were able to pull the data across 6 different networks that were delivering tele-ED in different ways. And so these findings are more generalizable. Most of the telehealth literature, vast majority of the telehealth literature is a single network. So this really adds to the generalizability of it. And finally, when we went and looked for the measures, and again, we had a number of factors like reducing the burden for these wonderful grantees that contributed all this data, we wanted to come up with a set of measures that we knew were really gonna hit the sweet spot. And so we went to CMS measures. And this worked very well because CMS has had a set of measures that hospital EDs need to report on. So consequently, all the rural hospitals were very familiar with these measures. They were used to reporting them. So we did not add to their burden very much in asking them to also send that data to us. On the flip side of that, we hope to influence policymakers, and CMS is probably the biggest influencer that we want in terms of possible payment restrictions, and to be able to go with them with solid research findings that indicate improved care using their own metrics, hopefully is going to resonate with them to a greater degree. So let me turn it over to Davis at this point.
Well, thank you, Marcia, and thank you, Jenny, both for those great presentations. I really appreciated the overview that you gave, Jenny, and then this deeper dive, Marcia. I'm going to actually start. There's a couple of clarifying questions in the chat box for Marcia that I thought would be good to just to tie up those details. And you know, and as I just mentioned, if you do have questions at any time, you know, please enter them in the chat box and make sure that you're directing it to the community of all panelists and attendees so we can all see what your question is. So just to clarify, are you able to tell us who the 6 network grantees were for these telehealth network development grantees?
Yes, University of Virginia, University of Kentucky, University of California, Davis, Avera eCare, which is in Sioux Falls, South Dakota, St. Vincent Healthcare, which is in Montana, and Indiana Rural Health, which is on the Indiana-Illinois border.
All right. I don't know if I could have called up 6 things like that so readily, so I'm impressed. These findings are really quite impressive, I have to say, on the evidence, you know, base for telehealth. So I really appreciate your sharing those. And I also see another kind of clarifying question here, which is inclusion versus exclusion criteria in the consult, and were they randomized?
This is a great question. We all know the gold standard randomized trials. It is very tricky in telehealth to do randomization at a system level. And I have to say, studies that I have seen where they have randomized in the emergency department for tele-ED tend to be really artificial in how they do the randomization. Like they set up another room outside of a standing emergency department and see some patients there and others. So a factor in all of this, so we were not randomized, clearly not randomized. And a factor in interpreting all of this and interpreting a lot of telehealth research, and I've got to say, telehealth and telemedicine covers all of healthcare and all of medicine. It can be applied just about everywhere. It's just a telecommunication and sharing of data and information on a patient, and often high density visual video connections and audio connections. So it can be applied absolutely everywhere. So it's such a huge, broad topic. But often when we're implementing telehealth, because of the nature of the technology and the networks, it tends to be a systems approach. And so to randomize at a system level is definitely challenging. So I have to say that a factor in interpreting our research is, yes, there is self-selection for all of this. The grantees, the 6 grantees decided to apply for this when FORP offered this as a funding opportunity. They clearly had reasons for why they decided to apply for it. So they were the hubs, the grantees, the 6 grantees, and then they reached out to rural hospitals, and who they reached out to and which rural hospitals agreed to be part of all this. There is a lot of self-selection. So that's at the system level. And then I mentioned the number of times, the percentage of patients where it was actually used. And that's a selection bias for the individual clinician that's in the rural ED that sees this patient and decides whether to press the button and pull in the consult or not. And so have to keep that in mind with all of this research, that there's selection at just about every level. I'm going to maintain, even for randomized clinical trials, there's selection on whether the patients volunteer for it or whether the clinic volunteers to be a site for it. That's my bias. I'm sticking that out there.
Well, you know, it's important to acknowledge those limitations, and I think it is important, as you rightly point out, that you know, most of our research is affected by limitations such as those. And so, and I'll just ask you one more question, and then I'll go over to Jenny. But since we're talking about limitations, are there other limitations about the work, you know, involving this approach, or other studies that you're doing with telehealth that we should be mindful of?
Good question. I'd say that self-selection is the biggest limitation. So we tried with our analyses to do matching. We did not have great metrics or data on severity, like in particular for stroke. So we were not able to do matching other than ICD-10 codes, age, some other factors. So those are definite limitations in comparing the telehealth patients against the ones where it was not used, the non-telehealth patients. So I'd say those are the biggest limitations on this. Sample size, we were very lucky because of this program with the 6 networks, but still over 26 months, we ended up with 4,000, which is nice. But then when you start slicing it down to individual conditions, because that's 44,000 patients where it was ever used for anything, when you start slicing it down, you get to a smaller end. So that's a limit for a lot of telehealth. You see a lot of single systems where the data is quite limited.
Yeah, telehealth in general, and then of course rural health research in particular. So, yeah. All right. Thank you. So now I have a question for Jenny, and you highlighted the research of the rural health research centers as we asked you to do, so rightly so. And you know, and I note that you pointed out it's the only federally funded research program that's entirely focused on rural health policy relevant research. And so, you know, it's been around for a long time. So a really significant player in the rural health research landscape. And I will acknowledge, you know, Rural Prep grew out of the Rural Training Track Technical Assistance Program, and you know, the part that I played in that, and the University of Washington was in the research on RTTs. And also, I would say the WWAMI Rural Health Research Center, which, you know, we also have. And so, so those help to build, you know, the idea, or develop the idea of Rural Prep. And so I'd say Rural Prep grew directly out of our FORT-funded experience. Is there other research that FORT funds, not in the Rural Health Research Centers program, that yields findings that are available to the public that they could find somewhere, whether it's in journals or published reports? And if so, could you tell us about that?
Sure, thanks for that question. Yes, our office either directly or indirectly funds a lot of research. The Rural Health Research Centers and the Telefocused Research Center are the ones that are designated to do that, but we have a plethora of, many of which are very new programs that are looking at research in different capacities. So we have the most recent, or one of the most recent programs, the National Rural Health and Economic Analysis Center, and that was awarded to the University of Kentucky, and they are doing a lot of research regarding economic impacts of rural hospital closures. And so they're so new, they haven't released any research yet, but it will be available on the Gateway as well. And then we also have the RCORE evaluation program, which is the Rural Community Opioid Response Program evaluation. And so we offer many grants in the RCORE world, so in the Rural Community Opioid Response Program. And so we have an evaluation cooperative agreement to look at the work being done in those programs and across the grants to produce research regarding opioids in rural communities. So they evaluate the impact and provide technical assistance and do different things like that. But they also produce research regarding the work that the RCORE grantees are doing. And then also we have the RCORE Rural Center of Excellence, and all these programs are relatively new, so they don't necessarily have a lot of research out, but it's definitely something to keep your eyes on or eyes open for, because when it comes out, it'll be very interesting. So the RCORE Rural Center of Excellence on Substance Use, there are two centers specifically that come to mind, the University of Vermont and the University of Rochester, and they're looking at evidence-based practices for future dissemination, and they're conducting timely pilot projects. So whether that's incentive-based prescriber-facilitated programs to promote buprenorphine treatment, or provision and evaluation of novel extended release buprenorphine. And then they're also looking at substance use disorders, specifically in rural Appalachian communities. And so that's another one. And then one that potentially Marcia could speak more to is the Telehealth Center of Excellence. And they are doing work in this sphere as well. So they are not directly doing research, but because of the work that they do with other regional telehealth resource centers, they collect a lot of data, ended up producing research from there. And then the final one that I'll talk about, because I could go on and on, is the Flex Monitoring Team. And the Flex Monitoring Team is a consortium of rural health research centers that look at the FLEX program, which is, it's another acronym, and it's flexibility, the Rural Hospital Grant Program. Yeah, thanks. And it allows small hospitals to be certified as critical access hospitals and offers grants. And so the Flex Monitoring Team does a lot of research regarding those grantees.
And, you know, just one thought occurred to me, and I don't remember if you mentioned this, but so obviously you talked about the Gateway, and, you know, I encourage everybody to sign up at the Gateway, and we had a webinar on the Gateway, but if you're not signed up there, that's where you'll get alerts. And they're not, you know, they won't bombard your inbox, but that will give you alerts on rural health research through these specific Rural Health Research Center programs. But the other stuff that Jenny is talking about, you may not see through the Gateway, but you may hear about it through the FORP announcements. Did you mention that? Because I would encourage people to, is it weekly announcements from the Federal Office of Rural Health Policy, where you get the kind of the policy lowdown, and then they usually highlight some studies that have come out.
Yeah,
Yeah.
thanks for pointing that out. It comes out every Thursday, I believe, and it is a weekly announcement. And then occasionally we'll have an expedited announcement for new programs that people can apply for.
You know, the gateway is phenomenal, as one of our attendees has commented. I was curious, though, in the landscape of rural health research, how you get on there. I know there's a section that's research in progress, for example. Is that only the Rural Health Research Center's research, or could anyone say, you know, I've got a grant, I've got a project going on, I'd like to get some input and I'd like to get publicity for this. How would they get listed on the Rural Health Research Gateway, if at all?
Yeah, so unfortunately, the Research Gateway only houses research from FORP-funded research centers. So it's not something that the public can necessarily get promoted on, but it does have amazing resources. And I know the last webinar probably talked about them, about how you can disseminate your work and resources that you can use. And then I'll also put a plug in for the Rural Health Information Hub, so the RHI Hub. So that's a place that, whether you've been doing work in a smaller capacity focused on a specific community or a specific state, you could contact them and they could also assist you in promoting your work on the RHI Hub, because they're always looking for promising practices and evidence-based practices to promote on their website as well.
Excellent.
So one of the questions in the chat from a while back, you know, so Rural Prep is focused on rural primary care, education and training of rural primary care clinicians. And this question, I think, is focused on those rural medical or rural health professions educators. And it asks, it's for you, Jennifer, have you at FORP ever thought of having a small research grant program that those of us who run rural training programs could apply to, something for faculty and or for students in rural programs? And noting these rural training programs are typically not in urban areas like the Rural Health Research Centers, and you know, we're in Seattle, so so any thoughts about that?
Yeah, honestly, I love that idea. I will say specifically, our research center funding is tied to legislation that advises us that we must do research on the national level. So it's not something that would come from that funding, but it's a great idea. And I'm sure the participant who asked this question is well versed in their state office of rural health, because it sounds like they've done their research and looked into opportunities for funding their own micro research. And so sometimes your state office of rural health will have opportunities for, or link you with opportunities for funding on a smaller scale. As of now, our office really only funds research that can be done at the national level. And so if you are in a rural area, in a rural training track, and you can do work at a national level, you are welcome to apply for these research cooperative agreements. No one is excluded. But that's why it typically trends towards universities and urban areas, because they're usually the ones who can house and have capacity to maintain the grants that we're asking for these huge national data sets and have access to RDCs and the data that needs to be done at the federally funded level. But I love the idea, and you're giving me food for thought, because I think that would be a really cool initiative within some of our maybe community-based division grants, because they focus really more on local initiatives, and this would be a cool idea for that.
Yeah, and I'm glad you pointed out that, you know, that word community, because these really, I think the scale that we're talking about really is in community, small communities, and community centric. And we've tried to take that approach in Rural Prep, even though, you know, we're based in an urban area. Randy's not, but we are. And so, but that is a challenge in rural health professionals education is, you know, big grants are available to the big institutions, and then to get people training in rural places and to support the scholarly activity that needs to go on there, you know, we need to find funding for those local community-based initiatives as well. So, so something to consider. I'm really glad that this was pointed out. And I also want, you mentioned the Rural Health Information Hub, and there's a comment here too, just noting that there is rural-centric research that is indexed there if a full text is available. So if it's a journal article behind a firewall, that won't be indexed there, but if it's publicly available in full text form, you can find that there. And I frequently have turned to RHI Hub when I'm approaching a new rural health research area that where I, you know, maybe know something, and there's just excellent rural health sort of, I would call them primers about different topics, and you can get connected to grant opportunities and you know, key background information and articles, and so I highly recommend the Rural Health Information Hub as well.
So I have a question. And that is, this is great to see all the interaction that goes on. Do the rural health centers actually participate in any kind of learning community where they give each other ideas or refer something that they've discovered to another center? What kind of interaction happens on that level, Jennifer?
Yeah, so the research centers, since they've been funded for so long, many of them have relationships with one another. I think Marcia is a great example of that. She works at the University of Iowa, and it's a consortium of multiple research centers that have grown in their different expertise and have come together to create a stronger entity. The FMT, the Flex Monitoring Team, is another example of that. There's not a specific learning designation for this to happen, but I think part of it is fostered in the work that the federal office does at the beginning of each year. When we're choosing our research questions, we get all of the research centers together in the same room. This year it'll be a virtual room, but we'll get them together in the same place at the same time, and everyone's talking about the work that they're doing, the work that needs to be done, what research is available, and it's a fun community to be a part of because everyone has their different expertise, and for the most part, it's not competitive because everyone's been funded at this point, and so it's very collaborative. And the National Rural Health Association puts on an annual conference every year, and every year the research centers come together to build panels that complement each other, because if you're doing work on substance use disorder, okay, you're gonna want the telehealth perspective, you're gonna want the behavioral health perspective, you're gonna want the disparities and communities of color perspective, you're gonna want all of these researchers working in different spheres on the same topic on your panel. And so they collaborate extensively with one another, and I think they do reach out to each other for subject matter expertise. And it's nice that that's happened organically, because there isn't a specific area or learning community that has been structured for them. So kudos for them just doing it on their own.
And sometimes that's the best way.
I think so.
Well, I was pleased to see that the individual who brought up the idea of small research grants is already engaged with Rural Prep as a mentor for micro research. And I am happy to see that idea at least catch some interest. Any other comments, Davis, or either Jenny or Marcia?
I have one more comment regarding the question about in the chat box. The rural health research centers could be told to offer some small research grants as another approach to stirring smaller scale research. That's an interesting idea. I'll definitely think about that a little bit. Definitely consider that moving forward. We're not always given the flexibility to be that directive with cooperative agreements in the federal government, just by nature of what we're told we're allowed to say and do. But I will say a lot of the research centers do have that interest naturally. While I don't know of any that have provided smaller grants, many of our research centers have started doing case studies. And so that's us asking them to do national level data analysis and research, and then them zeroing in on certain communities and bringing that qualitative and case study perspective to this national analysis. And so this isn't far off from that. And so I think that's a cool idea. And I implore you to go to the Gateway and look at some of the case studies that some of our research centers have done, and see how that aligns with your thinking, and think more about that and get back to me, because that's a cool idea.
Excellent.
I wanted to add that Forbes Office for the Advancement of Telehealth provides grants, and like the Tele-ED, we're doing a similar approach now with a more recent one of their grant programs, which has to do with school-based telehealth. So they've got 20-some grantees, and they are providing telehealth services in over 100 schools around the country. And so indirectly through whoever the hub is, the grantee, they are providing resources out into these communities to either get the equipment, or they're bringing the primary care providers through the telehealth to those communities. The most recent one that we're also doing collection of data and working with are grantees that were funded specifically for behavioral health. And so this is definitely in rural communities, small rural communities, expanding rural health capacity through telehealth into those communities. So there's a lot going on besides what Jenny has just talked about through the structure of the rural health research centers throughout FORP. And as she mentioned, there's a lot of acronyms and a lot of funding portfolios or programs. And because of the nature of rural, a lot of it ends up being small projects, a lot of small projects. And that's part of the strength, is across a lot of small projects nationally, getting the learnings from that.
Just one last comment. Of course, I have a lot of questions, but I just wanted to also note that FORP acts as a subject matter expert in other parts of HRSA and HHS to inform research agendas. And in fact, they review our rural prep research projects to help, select which ones we're going to do, even though we're funded out of the Division of Medicine and Dentistry. So I just wanted to acknowledge that role as well.
Well, thank you very much, Jenny and Marcia, for painting the big picture and then zeroing in on one particular area that's very relevant right now. That was great. In rural, things are very connected. You just need to know where they're connected. And sometimes just knowing a guide to help you through this really, really helps.
Thank you very much for the invite. This is a wonderful vehicle that you've developed for this.
Yeah, this was great. And please, anyone participating, feel free to reach out to me directly if you have any follow-up questions.
Yeah, and thank you for joining us.
So let me just say I lost my shared screen there for a moment. And I wanted to take the occasion just to point out some upcoming events. This is the first in this year's list of professional development webinars, and we've not yet settled on a topic for the December 17th event. That's going to be on the third Thursday rather than the fourth because of Christmas Eve. We're always looking for presenters and topics for both of these professional development webinars as well as Rural Prep Grand Rounds. Next month, we start our series of Rural Prep Grand Rounds for this academic year, and we'll be focusing on enhanced surgical skills for family physicians and how to train for that. The Rural Prep Grand Rounds is a team-based event, and so you have to sign up as a team, not as an individual. And I encourage you to go to the Rural Prep link that's on the slide here. We will be sending these slides to you for your participation today. We really are interested in your feedback and your evaluation of today's event. And here's a QR code. There's also a link in the chat that you can use to give us some feedback. And we'd really appreciate this because it helps us in the planning going forward. If you have any questions at all regarding rural prep or these webinars, please feel free to contact any one of the three of us in leadership for rural prep, or simply send a question to rprep@uw.edu. Any other comments, Davis, that I overlooked?
No, I think we're good. Thank you very much again, Jenny and Marcia. Great presentations and great discussion.
Excellent. Well, thank you all. To those of you who have participated, we're at the end of our hour. Have a good week and stay well.